So my talk is about the approach to the thyroid nodule. So I'll go through 4 heading: introduction and the algorithm for evaluation and management, few real world cases, and then I'll conclude. And I'll go very simple. And I'll discuss the doable things in our day-to-day clinical practice, which will help the clinicians and our students, those who are attending this program. Now, if we look into the thyroid nodule, the first question is how common it is. Now, being as an endocrinologist, we see a lot of thyroid nodule in our clinical practice, but how much relevant this is in a clinician's chamber. And if we look into this important prevalence study, then on palpation, 3 to 7% of the population have the thyroid nodule. So even for a clinician, it is not a very uncommon issue, but the fact lies that it is not evaluated properly by the clinicians. So we have to develop the awareness that the thyroid nodule is quite common disease, and 3% is almost like 3 to 7%, almost equivalent to the prevalence of diabetes in our country. So coming to the ultrasound and autopsy finding, it means that if you are looking more closely, more intensely, you will find that the prevalence will go up to 50 to 70%. And the prevalence actually increases with advancement of the age. So therefore, the prevalence is roughly around 3 to 7% if you are going for palpation. And if you are doing an ultrasonography, it may go up further and may go up to the level of 70%. So therefore, it is quite common disease, though we miss, and therefore there are many nodules which are very, very small and possibly can be evaluated only by ultrasonography, and possibly they will not require much attention. However, if we look into the prevalence of thyroid nodule, it is quite common. It increases with advancement of the age. It is more common in women and in iodine deficiency areas, and if the patient has got a past history of radiation. So therefore, this is a quite common disease which we may encounter in our clinical practice, and we must have some understanding how we should start evaluating a patient or a person who had a thyroid nodule. So there are a lot of causes of thyroid nodule. There is nothing much to learn from this slide, but the very important issue that we must learn that only a minor fraction of them are actually malignant. So among the say 100 cases of thyroid nodule, 94% is benign, whatever may be the cause, and only 6% is malignant. So therefore, our approach to the thyroid nodule is to identify those 6% or those minor fraction who actually harboring the malignancy. So that is the challenge in front of us, not to identify the cause of the benign thyroid nodule, but to evaluate but to identify the people, those who are harboring the malignant thyroid nodule. So therefore, objective of the evaluation of the thyroid nodule is basically based on this important understanding or important principle that we have to identify the malignancy in the thyroid nodule so that we can take some action and we can prevent the associated morbidity with the thyroid malignancy. Now, coming to this 10-year-old girl who presents with swelling in the front of the neck for 1 year, and she had no symptoms, either hypo or hyperthyroidism. And you can see that even though she did not have any symptoms of hypothyroidism, her FT4 value is lowish, and the TSH value is quite high, 23. Anti-TIP antibody is negative. So this child actually was suffering from overt hypothyroidism, no doubt about it. And as because she is suffering from overt hypothyroidism, so quite naturally we should start giving the replacement therapy. And majority of the patients who have overt hypothyroidism along with the nodule the best approach is to start the replacement therapy without doing anything further. However, we have looked into the thyroid scan of this young girl, and we have found that this patient actually had an absence of one thyroid nodule on one side. So it is a congenital absence of one thyroid lobe, and the thyroxine replacement was started. And in patient those who have a congenital hypothyroidism and there is an ectopic thyroid tissue, absence of thyroid tissue, or the congenital absence of thyroid lobe, in those cases, if there is a nodule, thyroxine replacement is associated with significant improvement, and we expect significant regression of the size of the thyroid nodule. Sometimes it disappears completely. It may not disappear completely, but that is the end of our evaluation, and that is the way we should manage. And these patients will require the replacement for the rest of their life, with some increment in the dose during certain periods of their life. Coming to my second case, the 45 years old female, she had a swelling in the front of the neck for 3 months, and there was some kind of palpitation. So she was quite lean, 158 centimeter height, blood pressure was normal. She looks a little bit of in the hyperthyroid state. There was a thyroid nodule on the left side. And if you look into the biochemical evaluation, you can see this patient has got overt hyperthyroidism with anti-antibody negative. So it indicates that we are not dealing with any autoimmune thyroid disease. Rather, there is a condition of hyperthyroidism which is not associated with autoimmune thyroid disease. So whenever we find that there is an hyperthyroidism, our next best option is to go for a thyroid scan. If you look into the thyroid scan, you'll find that this patient has got some uptake here on the left lobe and the suppressed uptake on the rest of the gland. So it indicates that there is an hyperfunctioning nodule here on the left side, and the rest of the gland is suppressed because this gland is producing, this portion of the gland is producing so much hormone that TSH is suppressed, and the rest of the gland, though normal, is actually suppressed, is not functioning at the point of time. So therefore, our diagnosis is toxic nodule. And if we look into the guideline, you will find that the toxic nodule should be treated either with 131 iodine or thyroidectomy. So therefore, we will not treat this patient with antithyroid drug. We'll treat this patient with either 131 therapy or thyroidectomy. In most of the situation, I treat the patient with 131 therapy, and we can expect a complete recovery, and the patient will not require thyroxine replacement therapy, in contrast to the Graves' disease where we give radioiodine therapy, and where, as Professor Chatterjee has pointed out in the last lecture, that all the patients will require thyroxine replacement therapy for the rest of the life. So this is the introduction, means that when we look into the thyroid nodule, then we have to think about the presence of hyperthyroidism and hypothyroidism. The first thing that we should evaluate is a thyroid function test, which will guide us. But these cases are not very common. So thyroid nodule with hypothyroidism and thyroid nodule with toxicity is basically not very common. Rather, the common variety is thyroid nodule with an euthyroid state. So coming to this algorithm, so if you have a thyroid nodule, then we'll go for TSH test or thyroid function test. You may have hypothyroidism, which I have discussed, and the patient will require thyroxine replacement therapy. And majority of the situation, the nodule will disappear. And if the patient is thyroid toxic, then you should go for a scan, and the patient, usually the patient have a hot nodule, which I have discussed in my last case. And the patient will require either radioiodine therapy or this surgery. Now, the common variety is basically the euthyroid state, solitary nodule with euthyroid state. Now, how we should approach? The approach may be of in two way, we can go directly for the FNAC. The one guideline suggests that you should go for FNAC, and the FNAC will give you either of the four report. So they can tell you that it is malignant, they can tell you it is suspicious, they can tell you it is benign, and or they can tell you it is insufficient. Material is insufficient. In insufficient material, you can actually repeat the test. You can do a repeat FNAC. And if it is a benign, then it is quite good finding as far as the reassuring finding as far as the patients are concerned. But if you find that it is malignant, then we directly go for the operation. And if it is a suspicious also, then we should think about looking for an operative option. Now, coming to the second option, how we approach that. After looking into the thyroid nodule, and if you find it is basically of euthyroid state, then we can go for ultrasonography. And on the basis of ultrasonographic scan report, we can decide that whether we can go for FNAC or will not go for FNAC. Now, this is in a thyroid neck ultrasound scan. And if the thyroid neck ultrasound scan is basically shows that the nodule is very small, that is less than 1 centimeter, then possibly we may not go for FNAC, and we actually just can observe the patient for a indefinite period of time for the growth of the nodule. And if the thyroid nodule is growing, then we can subject the patient for the FNAC. And especially if the patient is not fulfilling any suspicious criteria for the malignancy on ultrasonogram. Now, after the ultrasonogram, they can tell us that it may be a benign pattern. If it is a benign pattern, we'll see that how they can tell us that it is a benign pattern. Again, we don't require FNAC, and just we can observe. Then if the patient can have highly suspicious pattern, so we have to go for FNAC, or there may be some in between, there may be intermediate suspicion, low suspicion, intermediate suspicion, the area. So in those cases also, we have to do the FNAC provided the size is more than 1.5 centimeter or more than 2 centimeter. But in general, what we do that if the size is less than 1 centimeter, we usually don't go for FNAC. And if the size is more than 1 centimeter, then usually we subject the patient for the FNAC. Then after the FNAC, especially if the size is, your suspicion is high and size of the FNAC is more than 1.5 centimeter, 2 centimeter, we should look the cytological evaluation. And cytological evaluation should be done on the basis of Bethesda system, and they will tell us whether the patient has got a malignancy or not. Then the patient will go directly to the surgery, or the benign, where many patients will not require surgery, non-diagnostic when the repeat FNAC is required, or there may be highly suspicious lesion when many patients will require surgery, or there may be intermediate variety or the follicular lesions. Follicular lesion is very difficult to say whether they are malignant or they are benign as far as the FNAC is concerned. So it is now, it is basically reported as follicular lesion of undetermined significance, or the follicular nodule, or the follicular lesion with suspicion lesion. So something like that. So follicular lesions is in between. On one extreme there is a malignancy, another extreme is benign, and there is a possibility of non-diagnostic test where we have to repeat the FNAC. So coming to the ultrasound, as I have said that the ultrasound is the second best option in front of us after the FNAC, and we can do it after the thyroid function evaluation. So it provides a considerable anatomic information, but no functional information. determine the volume of a nodule, and very importantly, whether it is cystic or solid, because if it is a completely cystic lesion, they are always benign. Unable, however, to accurately predict the diagnosis of the solid nodule. So in those cases, actually, we require the support of the FNAC. So sonographic feature, they can tell us the size of the nodule, and they can tell us whether the FNAC is indicated or not. And third, whether we are dealing with a purely cystic nodule or not. And the purely cystic nodule, as I've told you, is basically indicates that it is a benign and FNAC is not required. So this is the different ultrasonographic feature. You can see benign lesion means that there's a very clear lesion, cystic lesion, and an echoic lesion, and there is a thin margin. So this is very typical of a benign lesion. On the other hand, you know, this is quite thick margin, and there is an heterogeneity inside the nodule, and calcification. So and these are the these are the calcifications. So these all indicates that there is a high possibility of malignancy. So this is the high suspicion area, and this is the benign. In between we have the others. So as you can see that the ultrasonographic report should come like a thyroid system, and there are actually 6 varieties. So thyroid 1 is normal thyroid gland, thyroid 2 is benign nodule, thyroid 3 is probably benign nodule. So up to thyroid 3, we can consider that we are actually dealing with benign nodule. Having said that, we must tell you in thyroid 3, the possibility or risk of malignancy is not 0, but less than 5%. However, thyroid 4 and thyroid 5 is basically high possibility of malignancy, and thyroid 6 is basically a case of malignancy. Now, when we are doing an FNAC or fine needle aspiration cytology, then you can see that this is this shows that 80% will actually benign. So therefore, as I've told you repeatedly, that when we look into the thyroid nodule, the possibility is that we will land up into a benign thyroid nodule in most of the situation, because as a whole possibility of benign lesion is close to 90%. And when someone is subjected for FNAC, even after then FNAC report shows that 80% is actually benign, and malignant is only 3 to 5%. However, another 5 to 8% may have suspicious lesion as well. So when you are doing an FNAC, how much is the sensitivity and specificity? The sensitivity is 83, specificity 92, but the issue is the false negative rate is 5%. It means that if the FNAC tells us that it's a benign lesion, till there's a 5% possibility that it is basically a false negative. So this 5% is very, very negligible, number one. And number two, as because thyroid cancer is not very aggressive, so therefore with FNAC, if it is a benign, we can stop further evaluation, and we can follow up the patient, and we can repeat the FNAC when it is required in future. So therefore, when we look into the algorithm of evaluation and management, if we take the thyroid nodule, we go for history and examination and TSH test to see whether the patient is hypothyroid, hyperthyroid, or euthyroid. I have already discussed about that what we should do if there is an hyperthyroid or hypothyroid. Next, we will go for ultrasound scan, and on the basis of the ultrasound scan report, we subject the patient for FNAC. Not everyone will require FNAC. As you can see, if the size of the nodule is very small without any suspicion, then we can leave the nodule and we may not go for FNAC. And even if the size is big, but if it is a completely cystic lesion, then also we we will not subject the patient for FNSC. Now, after doing the FNSC, we can get the non-diagnostic or benign or suspicion or malignancy. When benign will require follow-up, non-diagnostic will require the repeat FNSC, and malignancy will require surgery, and we'll discuss about the suspicious lesion. Okay. So coming to the real world study, so I'll show you 3 cases, one benign, one malignant, another is suspicious lesion. So this is a 22-year-old female, palpable thyroid nodule, which was noticed upon routine physical examination, no signs of hypo or hyperthyroidism. And you can see the patient is euthyroid, USG shows thyroid 3 and FNS show Bethesda 2, means that we are dealing with a benign lesion. So nothing much to do. Only reassurance is required. The patient should know that she is not suffering from or not harboring any malignant disease. They should be reassured that they are nicely evaluated, and we have ruled out the possibility of malignancy. So we have a lot of options. If the patient really wants to get rid of their swelling, then we can have some options for them. T4 suppressive therapy, percutaneous ethanol injection, and the patient can opt for surgery also if they really desire so, that they do not want that nodule in the neck for the cosmetic reason. There are other options like iodine therapy, laser, and radiofrequency ablation. So second case is the 42-year-old lady who has a nodular swelling in the front of the neck for 4 months, no signs of hypo or hyperthyroidism. You can see that the patient is euthyroid, USG thyroid, so thyroid 5, mixed solid and cystic lesion with punctate calcification. You can see the calcification here, and FNS shows Bethesda 6, and we suggested that possibly that she is suffering from papillary carcinoma. So the management is surgery. Now coming to the third patient, now here is a case which is basically indeterminate in origin, indeterminate in nature. This is a 43-year-old male, and his thyroid gland was not palpable. There is no nodule, but incidental thyroid nodule on the right detected while MRI spine was done for evaluation of low back pain. And you can see that there is a big thyroid nodule here, but on clinically it is not palpable, and clinically it was not observed. Now this patient was quite heavy, 89 kg body weight, no thyroid nodule seen or palpated, blood pressure normal. So we have looked into the thyroid report, clinical euthyroid, antibody negative, and CT scan of the neck shows a mass lesion with left lobe of the thyroid gland with retrosternal prolongation and cervical lymphadenopathy. And FNAC was done, which shows follicular lesion of undetermined significance. So this patient has got a follicular lesion, Bethesda category 3. So here is the issue that this patient has got some risk of malignancy, but we are not very sure. And therefore, this patient, how we approach this patient. Now, can we predict the malignancy beforehand? Now, when we face this question that there is a process by which we can predict the possibility of malignancy if we look into the presence of mutations. So these are the mutations which we can check: BRAF, RAS, RET, PTC, and this PPR gamma. So these mutations is now possible for checking because genetic studies is commercially available. So we can go for the evaluation of the mutations. Now these mutations, if present, they are highly predictive of malignancy. On the other hand, if they are negative, then the possibility of malignancy is very low, and we can go for lobectomy, and the patient will not require any extensive surgery or the total thyroidectomy. So therefore, approach will be different. Now, if the patient has got a positive mutation, we should go for total thyroidectomy, and if the patient has got a negative mutation, then we can go for lobectomy. or we can wait and repeat the FNAC and observe something like that. So therefore, more conservative approach if the mutation is negative, and we should be very, very aggressive if the mutation said positive. So we are dealing only the intermediate variety, so where the FNAC is not confirmedly told us that whether the patient has got a benign lesion or a malignant lesion. So coming to the mutation analysis of this particular patient, it shows that the mutation analysis was positive. So therefore, we subject the patient for the total thyroidectomy. And after the thyroidectomy, the histopathological diagnosis came. And you can see we were expecting many histopathological diagnoses. It may be papillary and follicular differentiated thyroid carcinoma. It may be follicular variant of papillary thyroid carcinoma, and follicular thyroid neoplasm with papillae-like nuclear feature, medullary thyroid cancer, anaplastic thyroid cancer. So this patient actually had this follicular thyroid neoplasm with papillae-like nuclear feature. So NIFTP. So NIFTP is basically a little bit newer terminology. Now this is basically a non-invasive neoplasm with follicular growth pattern, a very low risk of thyroid tumor. This is in inverted comma, not malignant, and tumor staging is not necessary. Lobectomy is favored over total thyroidectomy. Patients are not submitted to thyroid cancer protocol or guideline. So as because it came as a little bit benign kind of lesion, so we have not subject the patients for thyroid cancer protocols, and we have advised the patient to go for replacement therapy, and that's it. But however, if this kind of molecular testing is not available, then what we'll do, because this testing is quite costly and it costs roughly around 40,000 rupees. So if the patient can't afford this molecular testing, and in those cases, if you have follicular lesion of undetermined significance of your follicular neoplasm or follicular neoplasm, suspicious follicular neoplasm, any of this variety, then the surgery is basically considered and the patient should be subjected for the surgery. But in those indeterminate significance, if the patient can afford, then we can go for molecular testing and then we can decide our future course of action. So last part is my conclusion of my talk, that the thyroid nodule are quite common up to 70% of the general population. However, 65 to 70% of general population if you go for ultrasound evaluation of the general people. So this is commonly missed, but it is quite common in our clinical practice. Likely due to increased use of the diagnostic imaging, that is why we see a lot of thyroid nodule nowadays. Most of the thyroid nodules are benign. As I've told you, 90% of the thyroid nodule, or more than 90% of thyroid nodule, are benign. But we should evaluate to find out whether those minor number of patients who are harboring malignancy in the back of the thyroid nodule. The main goal is to identify the small subgroup of cancer in the nodule. Thyroid function testing, ultrasound, and FNA guide the initial management. And certain ultrasound features such as purely cystic appearance suggest a benign process, and molecular testing are indicated only in selected indeterminate cytology patients, and use of the ultrasound, fine needle aspiration biopsy, molecular testing facilitate a personalized risk-based protocol that promotes high quality care. With this, I conclude. Thank you very much for your patient listening.
Thank you. We have a few questions. I would rather go backward, starting with Professor Majumdar. He's on screen. The two questions for you. What do we do if there is discordance? A patient has TIRADS 4A and Bethesda 2.
If there is any discordance, as we know that all the methodology has got some flaws, some positive and negative predictive values. So we will be more, we'll go more with the higher score. So if someone has got a thyroid score high and FNA shows that they appears benign, then we'll go for the surgery, and we'll subject the patient for the surgery so that we will not miss those false negative cases with FNA.
Second question is, in these days where we are more into looking at patients on the digital platform, especially patients who come from far off, whenever we are treating thyroid disorder, would it be prudent to do a USG to pick up a nodule since it is present in so much %? Would it help?
I don't think so. I don't think there is any such guideline that we should universally do the ultrasound to
what he has said is they are not being able to examine physically, and even on at times they are not being able to see. So being medically safe, just not to miss whether it would be prudent to do an ultrasound. Guidelines regarding this, I don't think have been formulated as of yet.
Yeah, but whether it will be cost effective or not, it's really
cost benefit ratio would not be
very favorable, because majority of the nodule which we miss or which we don't see from outside, possibly of very small size, and they don't harbor malignancy. And even if they harbor malignancy, it is microcarcinoma, and the microcarcinoma, if it is present, it will not harm the patient.
More than often it's really detected on autopsy.
Yes, and microcarcinoma often detected in autopsy, and microcarcinoma, that even if present, when they will grow, even you have enough time to treat the patient. So there is no point of searching for the thyroid nodule by ultrasound universally to all patients. I don't think it will be cost effective. I think Professor Sudeep Chatterjee and Debmala Shanal is on board also, so they can
your opinion,
give their opinion as well.
Whatever the patient wants is best to do. You see, the problem is that patients have now got into this whole body checkup mentality, and they're going to check their body arsenic, cadmium, I don't know what else they want to check and what else is checkable. So that, if the patient wants to do, let them do. But I cannot possibly recommend that you go and get a thyroid ultrasound done just like that. When I know that, say, if you're in your 6th decade, 60% of you will have thyroid nodules, if like me. If you're in your 50th decade, like Anirban, then 50% people will have thyroid nodules. So I think it is it doesn't make any sense to me to have thyroid nodules, ultrasound of the neck done, unless you can actually see a nodule on a teleconsultation basis. But if the patient wants to do, if the patient wants, just like patients now want to measure their serum beryllium, if they want to do a serum, if they want to do an ultrasound, fine, let them do.
Sir, a question to you. Patient presents with postpartum symptoms of hyperthyroidism. Patient is breastfeeding. How to go about it?
Well, in the vast majority of cases, this will be a postpartum thyroiditis. And the postpartum thyroiditis actually, it is missed more often than detected. The best thing would be actually to wait and watch. Because if we, what should I say, assume it is thyroiditis, then very soon the patient will become automatically euthyroid and then hypothyroid. However, if you want to actually do it scientifically, then we have to get a technetium 99 scan done of the thyroid, and the baby has to be separated from the mother for at least 48 hours. And then the breastfeeding cycle goes for a toss, and it's probably not worth it. Unless the patient is very, very symptomatic, or maybe a nodule visible. In that case, perhaps one should go for all this and get the mother and the baby separated for at least 48 hours. It's not dangerous actually for the baby, but this is what the conventional recommendation is.
Another question, sir, which is linked to it is for a mother who is breastfeeding and needs an anti-thyroid drug, what is the choice of drug?
No, it is always carbimazole or methimazole. There's no question about it.
Okay.
PTU is only indicated for the first 3 months of pregnancy, nowhere else.
Okay. There is a question from Dr. Shamsundar Acharya to Professor Anirban Majumdar. What is your take on FDG PET positive nodules? Always an FNA?
No, if you're doing an FDG scan or FDG PET scan for some other reason, and if it comes, it shows positive nodule, it actually increases the concern of the cancer. So quite naturally, if there is a concern for cancer, then I think we should subject the patient for FNAC to get the confirmed diagnosis. The histological diagnosis is always necessary before we go or we subject the patient for any kind of invasive procedures.
There is a question to Professor Devmallo Shannal. If somebody's TSH is between 7 and 10, he is anti-TPO negative. Conventionally, till now, we thought that we don't need to treat. But from your presentation, it is evident that this patient has got high risk of cardiovascular heart failure, ischemic heart disease, etc. So someone anti-TPO negative between 7 and 10, NICE guideline says don't treat. But from your presentation today, we have come to know that they are at a high risk of cardiovascular disease, possibly 17% more risk. So what to do?
So again, first important thing is that, we need to do a repeat. You did not jump to testing because we need to retest at least after
6 months.
6 months, 3 to 6 months at least, and then confirm whether the hypothyroidism is persisting, because again, we have reversal from 6 to 30% of patients. And if it is persistent or it is rising, we can do a TPO antibody if it is, even if it is negative.
No, he is specified that it is TPO negative.
So if we can treat if the patient is young, persistent
40
hypothyroidism.
to 70 years, he is specified 40 to 70.
70, below 70 we can treat. Above 70 we shouldn't be treating because there is no benefit. Below 70 we can treat. Additional points, especially which we require, especially if the TSH is between 7 to 10, no point treating below 7, is if the patient is having a goiter, a dyslipidemia, planning pregnancy, family history. So these are additional points which favor treatment. But generally, if it is persistent hypothyroidism in a young subject, when the TSH is more than 7, hovering around 10, obviously we go for treatment, but not in elderly, because that is what we see in most of our cases. Elderly patients coming and, and not for obese patients again, because a lot of these obese patients with weight loss, they actually correct the hypothyroidism. So again, we shouldn't be treating those patients.
Thank you so very much. It was a very, very interesting discussion on the thyroid disorders. And